Now we will be learning about prevention of surgical site infections. Second after the COTI, the important component is surgical site infections and it varies in different countries कि किस कंपोनेंट की किस HAI की prevalence और incidence ज़्यादा है. There are many opportunities for the condition under which an SSI may develop during preoperative sections. The complete process, obviously preoperative, intraoperative and postoperative, continue and it contains the multitude of complex steps that are performed by a large group of healthcare workers. A breakdown in excellent IPC at any of these steps can cause or contribute to the infections. For this reason, every healthcare worker has responsibility for ensuring that all evidence-based practice are implemented at every step to prevent surgical site infections. In order to prevent surgical site infections, we need to reduce the bacterial count at surgical site as mentioned before in the heading of inoculum of bacteria. As risk factor of the surgical site infection, and there is a need to reduce that burden. Aseptic techniques, sterilization and other factors and practices can help in reducing the bacteria at surgical sites. The second one is preventive antibiotics. It can be described and obviously can be injected as per the half-life of the antibiotic. The third one is enhancement of host defense if it is weak. Next is prevention of infection-prone steps. For instance, ऑपरेशन थिएटर से पहले या ऑपरेशन थिएटर के अंदर और सर्जरी के बाद पेशेंट हैज़ हाइपोथर्मिया, hypoxia or hypoglycemia. These factors can support microbes to cause the infections. Then there can be delayed primary and secondary closures as per the need and the type of the wound in any procedures. There are many opportunities for the conditions under which a surgical site infection may develop during preoperative processes. WHO recommendations for prevention of surgical site infection 2016 states about how to prevent the SSIs. Patients with non-nasal carriage of Staph aureus should receive intranasal application of mupirocin 2% ointment with or without combination of chlorhexidine, and most importantly if it is with chlorhexidine. The second one, mechanical bowel preparation alone without administration of oral antibiotic should not be used in adult patients undergoing elective colorectal surgeries. In patient undergoing any surgical procedures, hair should not be removed or if absolutely necessary should be removed only by a clipper before entering to the OT, and shaving is obviously highly discouraged. It further includes surgical antibiotic prophylaxis should be administered before the surgical incisions when indicated. And surgical antibiotic prophylaxis should be administered within 120 minutes before the incisions, and it depends upon the type of antibiotic being used. And surgical hand preparation should be performed either by scrubbing with a suitable antimicrobial soap or water or using suitable alcohol based hand rub before donning sterile gloves. Measures for patient preparedness includes complete preoperative evaluation for scheduled elective surgeries and identify underlying conditions that should be managed. at least 30 days before scheduling the surgeries. This includes controlling the diabetes and sugar level and high blood pressures before any elective surgeries. Target blood glucose level should be below 200 mg per dl in both diabetic and non-diabetic patients. Maintain target blood glucose during pre, intra and post-operative periods up to 36 hours. Advise and assist the patient to cease smoking or use other tobacco product at least 30 days before elective surgeries. Advising and assisting patients to achieve a healthy weight, enhanced nutritional support, consider administration of oral and enteral multiple nutrition and nutrient enhanced nutritional formulas for the purpose of prevention of SSIs in underweight patients undergoing major surgeries. Enhanced nutritional formula contain any combination of arginine, glutamine, omega-3 fatty acid and nucleotides. Weight loss guidelines and support for overweight patients. Treating infection remote to the surgical site if possible, or postponing the surgery until infection has cleared. Recommendations that patients undergo elective surgeries where feasible in day stay surgery centers when available, rather than acute care hospitals to help decrease the risk of exposures to microorganisms in the hospitals. Educate patients and the relatives on the following topics to facilitate their involvement in SSI's prevention: the hand hygiene practices, pre-operative bathing or the shower, mechanical bowel preparations, obviously when it is indicated, rational use of antibiotics following surgery, and prevention of antimicrobial resistance. Now we will be studying about what measures are needed pre-operatively to prevent SSIs. We have discussed कि pre-operative mostly antibiotic prophylaxis दिया जाता है. The time should be calculated as per the half-life. Mechanical bowel preparation and use of antibiotics should be as per the need. And next, there are the hair removals. We have discussed it many times that the shaving is discouraged, and the reason mentioning the same thing again and again is to make sure that every one of you should have in mind to discourage that shaving practices going on in Pakistan. After that, surgical sterile preparation using alcohol-based antiseptic solutions of chlorhexidine. If it is not there, then any alcohol containing iodine solutions can be provided. Surgical hand hygiene and hand preparations. Perform surgical hand preparation by scrubbing with a suitable antimicrobial soap and water, or using alcohol-based hand rubs before putting on the gloves. Operation theatre has multiple factors that can cause or support infections in surgical procedures. So there are operation theatre preparations that have multiple factors to control HAIs as well. And it starts with the ventilation. Keep the movement of surgical team members in and out of the OT to a minimum level during the surgery. Keep the doors closed. Maintain positive air pressure ventilation for the OT. Ensure appropriate air exchange levels maybe up to 15 per hour. Airflow patterns, temperature 20 to 23 degrees C, and humidity 30 to 60% for the OTs with other than natural ventilation. Air should flow out of the OT, the cleanest area, and move from clean to less clean areas. For operation theatres with natural ventilation, ensure that OT is protected from dust, flies, and other insects, but this practice is not encouraged and it can only be done within extremely low resources. So it's important for you, अगर आप एक नर्सिंग स्टाफ हैं, आप एक डॉक्टर हैं, सर्जन हैं या कोई भी हेल्थ केयर प्रोवाइडर हैं, तो यू शुड नो एटलीस्ट द बेसिक्स कि ऑपरेशन थिएटर के अंदर कौन कौन से SOPs हैं और कौन कौन सी चीज़ें हैं जो अगर आप एज पर गाइडलाइन करें तो सर्जिकल साइट इन्फेक्शंस कम हो सकते हैं। और अगर किसी वार्ड में, किसी डिपार्टमेंट में सर्जिकल साइट इन्फेक्शंस रिपोर्ट हो रहे हैं तो सर्जन या रजिस्ट्रार कैन आस्क एंड इवेलुएट कि कहीं इस इन्फेक्शन की काज ऑपरेशन थिएटर में होने वाला उसका इन्वायरमेंट और उसके फैक्टर्स तो नहीं है, एंड देन दैट सर्जन कैन आस्क about the ventilations, about the flow, and obviously about the cleanliness. Second component is environmental cleaning of operation theatres. Follow environmental cleaning protocols and the guidelines to prepare the operation theatre for the first patient of the day. Between patients, अब एक patient हो चुका है and then there is a next patient in the waiting list. Focus on the cleaning and disinfecting the surfaces of surgical tables and storing areas. Carry out the cleaning of the OT at the end of the day, and we started with the start of the day, and follow recommendations for environmental cleaning of the operation theatres in national IPC guidelines and obviously in different modules of environmental cleanings. So whenever you are working in a hospital or health facility, just look around and see what components or what steps are being taken in your hospital. कौन से फैक्टर्स हैं जो इन्फेक्शन काज कर सकते हैं। मिसाल के तौर पे पेशेंट्स के दरमियान में जो सफाई हो रही है ऑपरेशन थिएटर की, वो किस लेवल की हो रही है। Either they are just removing those gauze pieces and just changing the sheet, or there is disinfection going on, especially in the surface of the bed and nearby areas. It's very important. Otherwise, we are just leading and causing infections to the patients. Use of good surgical techniques are important. Limit the length of the surgery. It's most important because more the length is, most the patient is on the operation table, it's open, more are the chances of infections. And then use minimally invasive surgical approaches if available. बहुत सारे cities में, hospitals में अभी available हैं for the different operations. Do use them if it is possible and available. Then handle soft tissue gently to avoid the crushing, which can result in the tissue death or the damage that can lead to the infections. Use either sterile, disposable or reusable woven or non-woven wraps to cover the surgical sites and surrounding areas during the surgical procedures. Use of good surgical techniques. Used closed suction drains that exit through a separate stab wound to help prevent accumulation of the tissue fluid in the dependent portion of the wound. Passive drains exiting through the bottom of the incision should not be used. Consider using impervious single-use disposable wound protector devices if available in clean, contaminated or dirty abdominal surgical procedures in adult patients. Irrigate an incisional wound before closure using a sterile aqueous solution of pyridine iodine followed by sterile normal saline solutions. particularly in a clean contaminated wounds. Use sphyrine iodine 10% in open abdominal surgeries and 0.35% in orthopedic spine surgeries. Surgical technique components also include use absorbable sutures whenever possible, and then preoperative, perioperative oxygenation in patients undergoing general anesthesia with endotracheal intubation for surgery. Provide at least 80% of the friction of inspired oxygen intraoperatively, and if feasible and possible in the immediate postoperative periods for 2 to 6 hours to reduce the risk of SSIs. Maintaining normal body temperatures is important to avoid SSIs. In patients who have anesthesia duration of more than 60 minutes, maintain core body temperature above 36 by using external warming techniques, including mechanical warming devices, heat preserving head and foot coverings, and patients with the blankets. Perioperative blood glucose control level is needed, so keep the blood glucose less than 200 mg per dl, both in diabetic and non-diabetic patients. Maintain adequate circulatory blood fluid volume. Use goal-directed fluid therapy intraoperatively to reduce the risk of SSIs. If appropriate resources and staff trained in administration and administering goal-directed fluid therapy are not available, ensure appropriate volume replacement, proper tissue oxygenation, and normothermia. Blood transfusion. There is no specific recommendation for blood transfusion of necessary blood component products. Obviously, it is recommended that transfusion of necessary blood components not be withheld just for the purpose to prevent the SSIs. But if it is not needed, then it should not be given. Wraps and the gowns. Use either sterile, disposable, non-woven or sterile, reusable woven wraps and surgical gowns as discussed in previous slides. And then there should be wound protector devices. If available, consider the use of these devices in clean, contaminated or dirty abdominal surgical procedure for reducing SSIs. Incisional wound irrigations. If resources are available, use irrigation of incisional wounds with an aqueous pyridine iodine solution before closure of clean contaminated wounds. There is insufficient evidence to recommend for or against use of sterile normal saline solution by itself for irrigation of an incisional wound for prevention of SSIs. Prophylactic negative pressure wound therapy. In some setting where resources are available, use of prophylactic negative pressures wound therapy in adult patients and primarily closed surgical incisions in high-risk wound may reduce the risk of surgical site infections. Generally, devices that create negative pressure between 75 to 125 mm of mercury for 1 to 7 days post-operatively are recommended. Antimicrobial coated sutures and use of these sutures are suggested for the purpose of reducing the risk of SSIs, but obvious है कि इसमें मज़ीद हमें studies की ज़रूरत है and that can support the claim. For primary closures and for the primary closed wounds, cover the incision that are closed with suture materials immediately at the end of the surgical procedures. Use sterile, dry gauze and absorbent dressings or occlusive dressings and secure in the position. When surgical incision is closed, the incision is usually covered with a sterile dressing for 24 to 48 hours. Beyond 48 hours, there is no need to cover the incision for prevention of the SSIs. Applying topical antibiotic is not recommended as these products have no additional role in reducing SSIs. Other than primary closed wounds, such as all incisions wounds should initially be packed and covered with a sterile moist gauze dressing and changed regularly. If gauze dressing moistened with sterile normal saline are used, they should be changed using aseptic techniques every 8 hours to prevent the gauze from drying out, otherwise it may damage healthy tissue growth. If sterile gauze filled with petroleum jelly or other moistening agent is used to pack and cover the incision, it is needed to change in less than or often 24 to 48 hours, depending on the type of the wound and manufacturer directions of the use of those jellies filled gauzes. Prevention of surgical site infection also includes the practices and activities going on post-operatively. Once the operation is done, patient is back in the ward या उसके बाद वो patient घर चला जाता है, तो those post-operative areas and times are also important in prevention of surgical site infections. The antibiotic prophylaxis for SSIs prevention should not continue beyond the completion of the operation or as per prescribed. Continue to monitor and control blood glucose level in post-operative period of up to 48 hours or until the tube feeding is discontinued. Cover the dressing and surrounding area to keep them dry while bathing. Educate patient and the family on hand hygiene and correct incisional site cares. Discharge patients as soon as after surgery to decrease the risk of exposures to microorganisms in healthcare facility. In our country ये एक प्रैक्टिस है कि जब भी कोई सर्जरी होती है तो पेशेंट्स मोस्ट ऑफ द टाइम दे से एंड दे इंसिस्ट कि उनको डिस्चार्ज ना किया जाए और हॉस्पिटल में रखा जाए. जितना ज़्यादा लेंथ ऑफ स्टे होगा मरीज़ का हॉस्पिटल के अंदर, उतना ज़्यादा वो मरीज़ डिफरेंट माइक्रो ऑर्गेनिज्म्स और इन्फेक्शियस डिजीज जो एजेंट्स हैं उससे एक्सपोज होगा और उतना ज़्यादा चांस है दैट पेशेंट विल एक्वायर एन इन्फेक्शन. सो अगर तो बहुत ज़्यादा ज़रूरत नहीं है तो मिनिमाइज एंड लिमिट द स्टे ऑफ द पेशेंट इन द हॉस्पिटल. बट उसके साथ जो सेकंड कंपोनेंट है वो ये है कि जब मरीज़ घर जाए तो उसको एक मुकम्मल तौर पर हिदायत दे के भेजा जाए, इंस्टेड कि जो उसकी डिस्चार्ज समरी है उसके पीछे लाइन में 2 या 3 पेजेस पे 2 या 3 लाइंस में कुछ गाइडलाइंस लिख दी जाए. इट्स इम्पॉर्टेंट कि वो गाइडलाइंस अगर लिखनी भी हैं तो वो उर्दू में लिखी जाए. उसके अलावा मरीज़ को 4 से 5 मिनट कम से कम बैठकर डिटेल के साथ तमाम प्रिकॉशन समझाई जाए. प्रिकॉशंस ऑफ मेडिसिन्स, ड्रेसिंग्स, वुंड केयर एंड ओवरऑल environmental cleanliness, so that patient should know that what activities she or he has to avoid and how that patient will maintain the hygienic condition so that there is no infections. Following are different recommendations about practices to avoid because they have no beneficial effect on reducing or preventing surgical site infections. And it includes, there is no need to perform routine microbiological sampling to identify the level of microbial contamination of air or the operation theatre surfaces. Do not screen the patient for extended spectrum beta lactamases. Do not use antimicrobial sealants to cover the surgical site after skin preparation to reduce the SSIs. And do not discontinue the immunosuppressant medications prior to the surgery to prevent the SSIs, especially in patients who need it. Do not use double gloves only for the purpose of reducing SSIs. They should be used for additional protection of healthcare workers. Do not use plastic adhesive incised drapes with or without antimicrobial properties for purpose of preventing SSIs. Do not perform special cleaning or the fogging or close the operation theatre after contaminated or dirty surgeries. But obviously a proper mechanism or a regular mechanism of cleanliness will be done in that operation theatre. The use of antibiotic preoperatively can significantly reduce the rate of infections. But it is important कि कौन सी एंटीबायोटिक देनी है, क्या डोज है, किस टाइम पे देनी है और किस हद तक देनी है, और उसके बाद उसका स्टॉप ऑर्डर. Particularly wound infections after certain surgical procedure, it's important. Selection of those antibiotics prior to the surgery will depend on a lot of factors, as I mentioned before, and are in low resource or lower middle income countries, the cost of antimicrobial will also be one factor. For most procedure, in an inexpensive first, second and third generation cephalosporin is recommended. For colorectal surgeries, due to the resistant anaerobe organisms, cefazolin with metronidazole is likely a better option than single agent of cefoxitin or cefotetin. In most instances, a single IV dose of antibiotic completed within 60 minutes before the procedure is recommended. The therapeutic level of antibiotic, however, should be maintained throughout the procedure. Dosing should also be adjusted for obese and morbidly obese patients. Antibiotics should be discontinued immediately postoperatively unless otherwise indicated. Managing surgical site infections include open and drain the incision, debride fibrinous debris and necrotic soft tissues, remove the foreign bodies, implement antimicrobial management as needed, manage the open wounds, and wound vacuum assisted closures. Now we will be learning about prevention of central line associated bloodstream infections. Choice of catheter is important to prevent the CLABSI, that's central line associated bloodstream infections. Right catheter for the right patient and the for right purpose. Site of catheterization is also important. For example, the chances of CLABSI are more in femoral as compared to the subclavian. So the next system that can lead to the CLABSI or can impact or affect that CLABSI is the barrier precautions. So these are very important to maintain if we want to prevent the CLABSIs. Education and the awareness should be encouraged. Patient and the family be educated and told about the care of central lines. Cutaneous antisepsis is another factor. Intravascular teams can support and prevent the CLABSI due to better expertise. Insertion site care and device maintenance includes IV device dressings, topical antimicrobial ointments, replacement of device if needed, if and when needed, guide wire exchange of central venous catheter, replacing delivery system, anticoagulant and thrombolytics. Use of novel technologies has helped a lot in prevention of CLABSIs, and it includes novel dressings. Anti-infective impregnated catheters, antimicrobial lock solutions, and improved catheter hubs. To prevent, please perform standardized central line insertion practices, perform hand hygiene, wear maximum possible sterile PPEs, Choose the best insertion site to minimize the infection. Choose the best size of the tubing. Avoid femoral site, especially in obese people, because in that case there will be more chance of clepsy. Prepare the insertion site with 0.5% chlorhexidine with alcohol. Place sterile gauze dressings. Perform routine dressings. If blood or blood products or the fat emulsions are administered, change the tubing every 24 hours. If propofol is administered, change the tubing every 6 to 12 hours. Conduct daily evaluation and remove the tube as soon as it is not needed. क्या हुआ?
बैटरी चेक कर रहे हैं, ठीक है? ठीक है। स्लाइड 90।
हाँ जी, यही है।
IVD.
There are different approaches as per the type of IVD to treat it. If the short-term intravascular device is suspected to have infection and patient has no obvious other source of infection, the culture has confirmed the infection, that shows that okay, the infection is with that short-term intravascular device. Then what? What can be the way to treat it? It is needed to remove the catheter, and if continuation of central line is needed, a new IV line should be placed but on a different point. But in case of long-term intravascular devices and it involving the infection treatment depend upon the multiple factors such as the type and the extent of infections, need for the long-term IVDs, etc. Bloodstream infections that might originated from tunneled and cuffed CVCs does not automatically mandate the removal unless there is persistent exit site infections. There is a risk of endocarditis or there is any infection of Staph aureus, then there is a need to remove the IVD and start the relevant antimicrobials. Antibiotic lock therapy has also shown the benefit in small research studies. Last but not the least, anti-infective therapies can also help in managing intravascular device associated bloodstream infections. There are multiple precautions needed to avoid the indwelling device associated infections. We have discussed different devices, for instance pacemakers, and there are multiple things to remember while placing it or post-operatively, and it includes that most of the similar precautions as discussed before in surgical site infections. There are precautions needed in pre-procedures, include preparations, skin care, hand hygiene, cleaning, and everything that was discussed in the pre-operative care, and then intraoperative and post-operative one. It also includes the prescription of antimicrobials. Continuous precautions of the devices before and post procedures are needed. And it is important that we should educate the patient regarding those devices. Now it's time to learn about the prevention of ventilator associated pneumonias. Because the mortality is so high, it's important to keep it in mind how to avoid it. Ventilator associated pneumonia can be prevented by immunization, staff education and involvement of infection prevention, prevention of person to person transmission such as using those hand hygiene practices and glovings, infection and microbial surveillance, respiratory care equipments, precautions for the prevention of aspiration, VAP prevention bundle that we will be discussing in coming slide, and fishbone diagram, just to understand what can be the causes that can lead to the ventricular associated pneumonia. Once we have that information, what can cause to the VAP, we can work on each those causes and prevent it. VAP can also be prevented by vaccination, as it was discussed in the previous slide. So the vaccination against pneumonia and influenza. The second component can be respiratory therapy equipment maintenance, hand hygiene. Hand hygiene is the step that can prevent all healthcare associated infections. It's our responsibility just to have an audit कि हमारे डिपार्टमेंट के अंदर हैंड हाइजीन कंप्लाइंस क्या है. आप देख सकते हैं कि क्या हर मरीज़ के बाद हैंड हाइजीन, उससे पहले और उसके बाद हैंड हाइजीन कंप्लाइंस की जाती है. अगर की जाती है तो क्या उसके कंप्लीट स्टेप्स किए जाते हैं या नहीं, क्या हैंड रब और दूसरे सोप एटसेट्रा मौजूद है या नहीं है. So we can obviously see in our own hospitals and settings how much the compliance of hand hygiene is there. The second component is avoidance of endotracheal intubation as much as it is possible, selective oral decontamination, subglottic secretion drainage, reducing the nasogastric intubations, start enteral feeding post 24 to 48 hours, and compliance with VAP bundle. So what is the VAP bundle? We will see it in the next slide. Care bundles, as mentioned in the previous slides, are important source to prevent different HAIs, and the care bundle of VAP help in prevention of the VAP. It includes that elevate the head of bed to 45 degree. Now obviously if there are the people who are working in the ICUs can see that how many patients have those bed elevations to the 45 degrees. If there is not, they can ask for it. The next one is daily station vacation and assessment of the readiness of extubate. एक मरीज को इंट्यूबेट किया गया है तो उसको डेली बेसिस पे असेस किया जाए if that patient is ready to move out. Peptic ulcer disease prophylaxis is important. Deep venous thrombus prophylaxis and daily oral care with chlorhexidine. It states the daily one, so it's an important message for all those who are working in the ICUs. It's important to make sure that all of these bundles are being done in your department. Only in that way you will be able to avoid VAP. So we have discussed HAIs, the types of HAIs, the surveillance and the reporting of HAIs, and how to prevent it. Now the question arises, who is responsible for all these activities of preventions? इन्फेक्शन प्रिवेंशन की एक्टिविटीज़ किसने करनी है? डॉक्टर ने करनी है, नर्स ने करनी है, लैब स्टाफ ने करनी है या किसी और ने करनी है? तो anyone who is working in the hospital as a healthcare provider should make sure that all infection prevention practices are being done. So if we start it with hand hygiene, and if you are working as infection preventionist, either an IPC nurse, are you part of IPC committee, you are part of management of the hospital or any department, you should make sure to see what's the audit of hand hygiene. What is the compliance of hand hygiene in the audits? How many healthcare providers are actually performing hand hygiene? What are the steps? What's the quality? And obviously, what is the overall rate? Because if hand hygiene is there, HAI will not be there. It's clear, right? So the next component for an infection preventionist, it is the patient education and awareness. Before moving forward, I'll also make one thing very clear, that in most of the hospital, there is no structured infection prevention department. So the responsibility of infection prevention comes to the registrar and the senior leadership of the hospital and the wards, nurses and doctors. So instead of waiting कि जी कोई इन्फेक्शन प्रिवेंशनिस्ट आएगा और वो ये सारा कुछ करेगा, तो जिस हॉस्पिटल में ये लोग नहीं हैं तो यहाँ हर एक हेल्थ केयर प्रोवाइडर की जिम्मेदारी है कि वो तमाम इन्फेक्शन प्रिवेंशनिस्ट की काम को मेंटेन रखे। द नेक्स्ट कंपोनेंट इज पेशेंट एजुकेशन एंड अवेयरनेस, द मोस्ट इंपॉर्टेंट कंपोनेंट। अगर पेशेंट प्रॉपरली एजुकेटेड है, अगर पेशेंट और उसकी फैमिली जानती है कि कौन से स्टेप्स करने हैं जिससे इन्फेक्शन बचाया जा सकता है, तो मोस्ट ऑफ द कॉम्प्लिकेशंस वहीं पे ख़त्म हो जाती हैं। सो इट्स द रिस्पॉन्सिबिलिटी ऑफ द सीनियर डॉक्टर, रजिस्ट्रार और द सीनियर नर्स, आइडियली द डॉक्टर वन, कि वो रैंडमली डिफरेंट टाइम्स पे पेशेंट्स के पास और उनकी फैमिली के पास जाए और उनको एजुकेट करे, स्पेशली जब डिस्चार्ज हो रहा हो। कंप्लीट हिदायत देना ज़रूरी है। इंस्टेड जस्ट आप एक पेज पकड़े, उसके पीछे 4 लाइंस लिख दें। बहुत सारे लोग पढ़ नहीं सकते होते, दे डोंट नो कि क्या लिखा हुआ है। तो इट्स इम्पॉर्टेंट कि वर्बली आप उनको जाके समझाएं एक एक चीज़। नेक्स्ट कंपोनेंट इज मॉनिटरिंग विजिट्स ऑफ हेल्थ केयर फैसिलिटीज डिपार्टमेंट। दिस कंपोनेंट इज फॉर दोज लीडरशिप्स, हॉस्पिटल लीडरशिप्स, दोज द लीडरशिप ऑफ द डिपार्टमेंट, मे बी द प्रोफेसर, मे बी द रजिस्ट्रार, बट इट्स अप टू देम कि वो जब विजिट्स करें दे शुड हैव ऑल आइडियाज कि व्हाट इन्फेक्शन प्रिवेंशन इज अबाउट एंड व्हाट डिफरेंट एस्पेक्ट्स दे आर गोइंग टू लुक फॉर। द नेक्स्ट कंपोनेंट इज द ट्रेनिंग ऑफ एजुकेशन ऑफ हेल्थ केयर स्टाफ। आइडियली जब भी कोई नया हेल्थ केयर प्रोवाइडर, चाहे वो नर्स है, चाहे वो डॉक्टर है, चाहे वो जेनिटर स्टाफ है, जब भी वो हायर होता है आइडियली उसकी ट्रेनिंग होनी चाहिए। और देन देयर शुड बी रिफ्रेशर ट्रेनिंग ऑफ ईच एंड एवरी हेल्थ केयर प्रोवाइडर। अगर ज़्यादा जल्दी नहीं हो सकती तो एटलीस्ट वंस इन अ ईयर। सो ये जिम्मेदारी किसकी होगी? हर डिपार्टमेंटल लेवल पे डिपार्टमेंटल लीडरशिप की और हॉस्पिटल लेवल पे हॉस्पिटल लीडरशिप की। बट अगर आपके पास इन्फेक्शन प्रिवेंशन का डिपार्टमेंट है तो देन इट इज़ द रिस्पॉन्सिबिलिटी ऑफ इन्फेक्शन प्रिवेंशन डिपार्टमेंट कि they make sure that these trainings are being done. The next component is advocacy to health facility management and clinical teams for IPC committees and IPC teams to continuously visit those management teams and make them realize why infection prevention is important, why hand hygiene is important, why the waste management is important, why the reporting of HEIs is important, and all those activities. Then the follow-up from the lab regarding timely reporting of HEIs. अगर सैंपल चला गया है तो ये नहीं कि उसको वो लैब के अंदर एक हफ्ता और मोर देन एक वीक तक रिपोर्ट नहीं आ रही। मेक श्योर दैट रिपोर्टिंग इज ऑन टाइमली बीइंग। टाइमली बेसिस पे अगर रिपोर्ट हो रही है तो तब ही आप उसका एक्शन ले सकते हैं, उसको ट्रीट कर सकते हैं और नेक्स्ट को आप प्रिवेंट कर सकते हैं। द नेक्स्ट कंपोनेंट इज डाटा एंट्री क्वालिटी एश्योरेंस। ये नहीं है कि किसी आप अनट्रेन्ड बंदे को डाटा रिपोर्टिंग पे बिठा दें और उसको पता ही नहीं है कि वो क्या रिपोर्ट कर रहा है। सो इट्स द रिस्पॉन्सिबिलिटी ऑफ इन्फेक्शन प्रिवेंशन टीम टू ट्रेन द डाटा रिपोर्टिंग एंड मेंटेन एंड मेक श्योर कि वो जो डाटा रिपोर्ट हो रहा है उसकी क्वालिटी अच्छी है। नेक्स्ट कंपोनेंट इज द टाइमली फीडबैक एंड एक्शन पॉइंट। जब भी आपके पास HEI की सर्विलेंस की रिपोर्ट आएगी तो इन्फेक्शन प्रिवेंशनिस्ट का काम है कि वो उसको एनालाइज करे और उसका फीडबैक दे और डिफरेंट स्टेप्स बताए जिसमें वो इन द फ्यूचर दे कैन स्टॉप एंड दे कैन प्रिवेंट द HEIs and implement HEI surveillance through IPC committee with help of IPC teams. So this all about the roles and responsibilities of infection preventionist. But make sure जिस हॉस्पिटल में infection preventionist नहीं है वहाँ आप सब infection preventionist हैं। सबकी रिस्पॉन्सिबिलिटी है कि वो इन्फेक्शन प्रिवेंशन पे काम करें। इवन इन दोज हेल्थ फैसिलिटीज जिसमें इन्फेक्शन प्रिवेंशनिस्ट मौजूद है, दे कैनॉट डू इट ऑन देयर ओन अलोन। ये कम्युनिटिव एफर्ट है। जब हर डॉक्टर, आई एम सेइंग इट अगेन, हर डॉक्टर, हर नर्स, हर जेनिटर स्टाफ प्रॉपरली केयर कर रहा होगा तब तमाम इन्फेक्शंस प्रिवेंट हो रहे होंगे। दैट इंक्लूड्स दोज HEIs एज वेल। So this is all about HEIs। अगर मैं इसको समराइज करूं तो हमने स्टार्ट किया HEIs से, उसकी डेफिनेशन से, and then we came to different types of HEIs. Then we saw how the surveillance can work, how these HEIs can be reported. Before going forward, तमाम वो हॉस्पिटल्स जहाँ पे HEI का सिस्टम नहीं है दे कैन डू इट कि वो अपने वार्ड लेवल पे, अपने हॉस्पिटल लेवल पे एटलीस्ट मैनुअली दे शुड हैव अ रिकॉर्ड। जब उसके पास एक सिस्टमेटिक सिस्टम आएगा तो वो आइडियली उसके अंदर ऐड हो जाएगा। सर्विलेंस के बाद हमने इसकी प्रिवेंशन पढ़ी। Prevention started from obviously standard precautions, transmission based precautions, and then the care bundles. And in the end, we saw what is the role of infection preventionist. So this is all about the HAIs, healthcare associated infections. In the next slide, you will see different references. And if there is any questions or any suggestion, you can write in the comment section in the end. And best of luck.